Next speaker is Dr. Praful Kerkar, who is going to speak on SGLTi2 inhibitors in REF.
At the outset, thank you, Dr. Mahapatra, for this invitation, and good afternoon to all chairpersons and my co-faculty and the viewers. Thank you so much. So I will put a case-based presentation. I'll also show two cases and show the impact of SGLTi2 inhibitors, the new kids on the block. These are exciting times in heart failure management, and it's always a pleasure to follow Dr. Ponde, who has told us all about the ARNI molecule itself. But besides that, there were not one but two very landmark trials on dapagliflozin and empagliflozin in the last couple of years rather, and also one on Soloist, which is actually an SGLTi2 1 plus an SGLTi2 inhibitor and not available for use here, and was used in diabetics for both HFrEF and HFpEF. So yes, this is the mantra, modern day mantra today. Based on these game-changing trials, SGLTi2 inhibitors have become the fourth pillar of foundational therapy. And the mantra is that somehow you should get patients within the first 4 weeks on these four pillars. And towards that end, let us see what is the contemporary approach to the treatment of heart failure today. That it dictates that you should be clinically oriented as always, and however acknowledge the importance of evidence-based therapies. But when moving away from trials, as you come to the real world, you need to be practical and individualized treatments based on the patient characteristics, their tolerances, intolerances, and access to meds. Emphasize on initiation of all these four pillars and initiate multiple drugs, not necessarily on the same day, but then up-titrate to the maximally tolerated doses. So here is the 69-year-old woman who has come with breathlessness and ankle edema for 3 months to a cardiology OPD. The past history is not relevant in the sense non-diabetic, non-hypertensive, ejection fraction 30%, a good eGFR compared to the case that Dr. Ponde showed us, and that the patient was naive to heart failure medications, no drugs, first time detected. Vitals are pretty okay, but the heart rate is, of course, high. So given the good blood pressure, great renal function, significantly high heart rate, how do we treat her? What order would you start those four pillars as I talked about? I would, for one, start beta blocker and SGLTi2 inhibitor. Well, which you start with is all your choice, as Dr. Ponde showed about starting with ARNI. Sorry, my phone rang there. Yeah, so I would start with beta blocker and SGLTi2 inhibitor because beta blockers arguably most effective for risk of sudden death prevention. And SGLTi2 inhibitors have a striking early benefit on hospitalization for heart failure and may mitigate the short-term risk of worsening heart failure with beta blocker. And then I would go on to starting ARNI and this. Now, this particular paradigm, even Dr. Ponde alluded to, and it was given by none other than Dr. John McMurray, who was responsible for introducing the ARNI molecule about 7 years ago. So the rationale for this rapid initiation is that much of the benefit of heart failure medications, all the four pillars, so to say, is seen within the first 30 days. And we want to grab that opportunity. And addition of a new drug class yields greater benefits than dose titration of existing agents. Morbidity and mortality is reduced even with the low starting doses, and magnitude of the treatment benefit of each drug class is independent of the background HFrEF therapy, and thereby you get an improvement in safety as well as tolerability of these medications. So will you start them at the same, all four together in this patient who is naive? The pros of starting all four together, as I mentioned earlier, is that at least all four are on board, unlike up-titrating is what Dr. Ponde followed in the previous case. And the con is obviously, though the blood pressure is okay, 2 out of these 4 drugs, that is ARNI as well as the beta blocker on top, is likely to, your blood pressure can be affected. Of course, the patient would also be on a diuretic, and the euvolemic state is all important, as so well Ponde alluded to. Starting all 4 drugs at once, you will be difficult to sort out an adverse effect if it occurs, which is related to which drug. Especially, I would be concerned about starting both ARNI and MRA together as an initiating therapy because it can increase the risk for hyperkalemia. And also, therefore, I don't advocate starting all 4 drugs on the same day for this drug-naive patient. Moreover, you need to get the patient's confidence. If first-time presenter gives so many drugs together, 4 drugs in 4 weeks is a good starting point. Why SGLT2 inhibitors? They're easy to use, don't require much up titration, a single dose 10 milligram per day, whether it is EMPA or DAPA, and no up titration needed, very few absolute contraindications, overall safe and well tolerated, minimal or hardly any effect on blood pressure and heart rate, significant benefits in cardiovascular outcomes, which I'll allude to, which I'll show you later, and renoprotective in the long term, minimal hypoglycemia even in non-diabetics. This patient can, given our only class 2 symptomatology, can very well be managed in the outpatient clinic itself and bring her back after 1 week for renal function and electrolytes, though we haven't yet started on ARNI, but we want to look, the initial drop in eGFR might happen with this patient and before introducing ARNI. And of course, today in COVID times, all patients can monitor their home blood pressure as well as heart rate. They're so gotten used to it, at least their families have gotten used to it. And that is what I would do besides weight monitoring for your patient. Now, what do you tell when you your patient when you start SGLT2 inhibitor? Safe, well tolerated, and that you're going to live longer, as also that your heart failure hospitalization is going to be less. Most importantly, counseling them about genital mycotic infections and the role of personal hygiene, not only in preventing, but also in treating this genital mycotic infection, and the ease of treating these infections with local or oral, generally due to candidiasis, these infections are. And you can easily treat them. Minimal or nil BP lowering effect or hypoglycemia, and safe in our patient, though she is not diabetic. This was well shown in the DAPA HF trial, where you see the adverse events of interest, those which were related to, in the previous previous SGLT2 trials for in diabetic patients, like volume depletions, renal adverse events, fractures, amputation, major hypoglycemia, diabetic ketoacidosis, absolutely comparable to placebo and not at all statistically significant. In fact, renal adverse events were lower because, as I will show you later, it is a renoprotective drug, and even in the acute stage, the renal adverse events were not much. As also, any serious adverse event leading to drug discontinuation was actually lower in the dapagliflozin arm, given its benefit for reducing hospitalization as well as death. And there is much hype about urinary tract infections from the previous trial that was there in the CVOT trials, but hardly any compared to the placebo, as you can see here, absolutely not significant. If at all you need to get worried about genital infection, which in this particular trial were numerically higher, but not statistically significant, and genital mycotic infections can be easily dealt with. And these 3 events which we are most worried about is hypoglycemia, diabetic ketoacidosis, and Fournier's gangrene, about which there was a red flag. You would see them only in this particular trial in the diabetics, as also so small a percentage, 0.1 and 0.2. And here, in fact, Fournier's gangrene was not there in the DAPA arm. Now, coming to the next case, again presenting with breathlessness and ankle edema, a known patient of heart failure coming into the cardiology OPD now with increasing breathlessness and worsening heart failure, so to say. And she has had a heart attack before, is a COPD patient, elderly with atrial fibrillation going on also. She's on EF of 35%, but her eGFR is going down to 40 ml per minute compared to the previous patient. She's on furosemide, ramipril, carvedilol, BID. From carvedilol perspective, for an AFib perspective, heart rate is 78 and her blood pressure is 110/62. Now, what are you going to do? Are you going to switch her? Dr. Ponde decided to switch, I guess, in the first patient from ramipril to ARNI. No doubt ARNI has got such benefit. She's currently on some kind of a RAS blockade, as well as a beta blocker and a diuretic. And after having adjusted the diuretic dosages, are you going to start these 2? So my approach to this patient is on ACE inhibitors and beta blocker, as also the renal function on the brink, I would rather immediately start with SGLT2 inhibitor, given its osmotic diuretic effect, which we are anyway going to add on to our heart failure, and the renoprotective effect, as also the improved renal outcomes, which I will show. And then switch to ACE inhibitor to ARNI once the renal function is stable, and then add an MRA. But so even the ACC update, which Dr. Ponde alluded to, talks about patient being on some combination of triple drug therapy. Of course, this patient, although not being on ARNI, but being on ACE inhibitor, I would add an SGLT2 inhibitor going by these guidelines too. And what are the CV outcomes? We are all aware of it. We need not repeat these again. But yes, up to a 25% relative risk reduction, identical trials, both DAPA as well as Emperor. And benefits, if you were to see this, as early as 28 days with dapagliflozin, the arms start diverge. So for grabbing these early benefits, get the patients onto early SGLT2 inhibitor in both the arms. As also a meta-analysis showed that the 25% relative risk reduction occurred in the primary endpoint. Not only that, but also for all-cause mortality, there was a 13% reduction. And in the same trial, whether the patient was on ARNI or not receiving ARNI, the effect was very much there. There was no heterogeneity, no subgroup interaction, p-value not being negative, is not being significant, which is what we expect here. And that the estimate was even better, point estimate was even better in patients receiving ARNI. So there is nothing to choose between ARNI and SGLT2 inhibitor. We want to choose both agents, and they are additive and can and should be used together. Having said that, what about just not adding life to just years to your life, but adding life to your years? Quality of life improvement shown in both DAPA and the Emperor trials, as also the renal outcome that you saw here in the Emperor reduced trial. As you can see, a deterioration of eGFR in terms of measured by the slope was reduced along the length of the trial, you can see. Albeit there was one initial drop of about 15% seen in both the trials. And I just added this trial. We do not exactly know the mechanism of action of this SGLT2 inhibitors, but this reverse remodeling, which Dr. Ponde was talking about, is also being worked out post-hoc in EMPA trials. As also the risk of ventricular arrhythmia, coming down, ventricular arrhythmia, resuscitate cardiac arrest, or sudden cardiac death. In this post-hoc analysis, you see it was down by 21% in the DAPA arm. Having said that, that small initial reduction in eGFR that I was talking about is expected because of the osmotic diuretic effect, about 10 to 15% drop in the first 2 to 3 weeks. Be patient there. Don't have to stop DAPA or EMPA for it. However, if there is eGFR reduction, which is in a large magnitude, you need to evaluate volume status. As in Dr. Ponde's case, whether the diuresis was too much. That could be the common reason. And that, again and again, I'm harping on the point that SGLT2 inhibitors are renoprotective. Hardly any contraindication. Type 1 diabetes due to the increased risk of diabetic ketoacidosis or known hypersensitivity or patients on dialysis are the contraindication for SGLT2 inhibitor. And this is from the ESC Heart Failure Association, a position paper about tailoring medical therapy according to the clinical profile of the patient. And then they identified 11 profiles here, 11 phenotypes based on their blood pressure, their heart rate, the presence or absence of AF, CKD, hyperkalemia, and hypertension. And in all of these, SGLT2 inhibitors are recommended for all these patients, including ones who have CKD or hyperkalemia. So having said that, we all need to know of these 4 foundation pillars, their target doses. We can't be on homeopathic doses. So all of this is a good chart to follow and keep in mind. as also again reiterating the point that here the initiating dose as well as the target dose is the same with just one dose. 10 milligram is all that you need to remember. But the priority is to address all pathways with low doses as soon as possible. Target doses are the ultimate goal, and up-titrate the medication based on how they tolerate it, especially the renal function, the heart rate, and the blood pressure. That's the mantra. So what happens now? This is extremely important slide, I feel, for us to understand. If all these 4 pillars in optimal doses are given to our patients of heart failure, especially the first patient, if we get him onto all these 4 and then up titrate, over the next 2 years, if you had not given any medication, the absolute mortality would have been 35%. Whereas if you have used this quadruple therapy over the next 2 years, you will bring it down by 25%, an absolute risk reduction of 25% and a relative risk reduction of 73%. Huge, isn't it? So NNT with all 4 medical therapies to prevent 1 death is 4. And I will leave you with this one slide, as far as the slides are concerned. I don't know if I'm exceeding my time. So wherein an estimated survival with all these 4 foundational therapies was done in this beautiful paper for Lancet. And it's a good starting talking point to your patients when you try to tell them to be on this polypharmacy, that if at the age of, they compared this with the previous trials of beta blocker RAS inhibitors, and then they looked at what if these patients were on conventional beta blockers and RAS inhibitors, whereas how they would fare with SGLTi2, ARNI and MRA on both, all the 4 foundational 4 therapies, ARNI replacing RAS inhibitors. And if you were a 55-year-old when you got your heart failure and you were started on these 4 foundational therapies, you would get additional benefit of 6.3 years in terms of survival, the estimated survival of those. And even an 80-year-old is going to live by a year and a half longer. That is what is the kind of a paper this was. And I will leave you with this quote from James Januzzi, one of the persons who was there in the guidelines that the ACC document that Dr. Ponde was alluding to. One of the easiest agents to add to existing medical therapy can be used in patients with new onset HFrEF. And he says that he has used it also in ADHF. Having said that, for in-hospital initiation, we have some data from after the IV diuretic doses have stopped. We have some data from soloist, wherein worsening heart failure was a inclusion criteria to include these patients. In general, do not reduce the diuretic dose is what he talks about, like is done when starting ARNI, because blood pressure drop is not an issue with this drug, and provide education to the patients about possible increase in diuretics, especially when you are on both ARNI as well as SGLTi2 inhibitor.